Welcome back. Today we are presenting a new case. So let's start. A young lady admitted for some other illness, but now she is experiencing urination pain, frequency, and a low grade fever while she is in the hospital. Her urinary catheter is removed and her urine is transported to lab for testing. More than 160,000 colony forming units per ml of a catalase negative, salt tolerant gram positive cocci showing ampicillin susceptibility were found in the lab. What it could be, what is the most likely diagnosis, what is the pathogenesis, what are the investigations that you would like to do, how would you confirm your diagnosis, and what is the treatment. So I give you guys few seconds to think about it, what it could be. So you have guessed it right. It is an hospital-acquired urinary tract infection. And the causative agent here is Enterococcus faecalis. Now, how so? We will learn that how I come to this conclusion based on the information provided in the question. But we are very sure that enterococci are one of the most common cause of healthcare associated infection due to their high antibiotic resistance. Because all strains, they are resistant to cephalosporin and some of them are also to the vancomycin. So what is the pathogenesis of Enterococcus? So basically, these are the normal flora of intestine, as the name itself suggests. Entero means intestine, but they are also present in biliary tract, genitourinary tract. So they overgrow locally when normal flora is reduced by broad spectrum antibiotics such as cephalosporin. And then they can cause urinary tract infection or biliary tract infection. Sometimes bacteria may enter bloodstream when mucosal or epithelial barrier is compromised or disrupted, for example, in case of bed sores or IV drug use, and they can cause systemic infection. And then they can involve heart valves and cause subacute bacterial endocarditis. An enterococcal infection is a common complication of biliary as well as hepatic surgery. Enterococci and Viridian streptococci colonize previously damaged valves by a group-based streptococci and rheumatic fever. So, which investigation we should do? We should do urine as well as blood culture. If you are suspecting UTI, you should do urine culture, or you are suspecting that it may enter bloodstream and cause systemic manifestation, then you should go for blood culture as well. So they are gram-positive whole cocaine pair, which are catalase negative. They may show alpha, beta, or gamma hemolysis. Pneumococcal tests are negative, that is, optogen resistance, uh, biosolubility is negative, and inulin fermentation is also negative. Then we will do bile esculin test and group D test, which has to come positive. And to differentiate it from non-enterococcal group D positive and bile esculin positive cases, there are two tests. It can grow in 40% bile and 6.5% NaCl. These are very extreme conditions. So these are resistant bacteria. Now, there are only two uh, and there are many species of enterococci, but there are only two motile enterococcus. Usually coccus are not motile, but these two are motile, that is Enterococcus caeciliiflavus and Enterococcus gallinatum. Why I am uh, going into so much detail about this? Because these two species, they are showing intrinsic resistance to vancomycin, and vancomycin is one of the drug which is commonly used to treat enterococcal infection. So we have to be sure that these two species are not one of the enterococcus which is causing infection in the patient. Sometimes they show yellow pigments on growth, but basically these are motile enterococcus and they show intrinsic resistance to vancomycin. Now, two most common species which cause majority of infections by enterococcus is Enterococcus faecalis and Enterococcus faecium. Enterococcus faecalis being more common. Why this speciation is important? Because their drug resistance pattern is different. So how we can differentiate them? Enterococcus faecalis is susceptible to ampicillin, but it is resistant to quinopristine and dalfopristin, while the reverse is true for Enterococcus faecium. And Enterococcus faecium also show resistance to aminoglycoside or tobramycin. So it is more resistant bacteria, difficult to treat compared to Enterococcus faecalis. Uh, any biochemical test? Yes, arabinose fermentation, tellurite taste positive, and pyruvate taste positive. These are the tastes which are positive in Enterococcus faecalis, while all three are negative in case of Enterococcus faecium. But Enterococcus faecalis somehow causes more virulent diseases like endocarditis, while faecium is less virulent and causes less diseases, severe, that is endocarditis. So this differentiation is important in case of Enterococcus because it impacts your treatment option. Not all biochemical reactions are important to learn, but one which helps in speciation difference, which may impact clinical management, are worth to learn and to focus for. So let us go with the treatment. So treatment is basically ampicillin and vancomycin. You can choose any one of them depending on your hospital antibiogram, along with aminoglycoside. So both this drug, they show synergistic combination. Why? Because this beta-lactam or vancomycin, they facilitate intracellular uptake of aminoglycoside, and then aminoglycoside will exert the bactericidal action. As we know, vancomycin inhibits enterococci by binding to cell wall precursor and disrupting the cell wall synthesis. But uh, there are vancomycin resistant enterococci also, in which they strains produce modified cell wall precursors. So vancomycin cannot bind to the bacteria. So in such cases, you should use linezolid and daptomycin. I'm not recommending quinopristine or darfopristine because if it is Enterococcus faecium, they may show intrinsic resistance. Vancomycin dependent enterococci, that means strains have lost the capacity to synthesize their native cell wall and must instead rely on vancomycin to promote the creation of altered cell wall precursor. That means vancomycin is now necessary for the survival. So in such cases, you should avoid giving vancomycin. So that's it. So I hope you have learned some important information regarding enterococcus and it will help you in your exams or in clinical practice. So stay tuned to the channel, subscribe to it, and share it with your friends and colleagues. Thanks. Bye bye.